There's a need to better detect and prognosticate dementia in efficient, cost-effective ways, especially in light of the emergence of disease-modifying therapies. And we are used to really getting detailed cognitive assessments to try to find that at-risk group. Historically, our at-risk group has been mild cognitive impairment. And then even earlier, if we're looking for preclinical dementia, we're looking for people with ostensibly normal cognition who might have some subtle differences or changes that could then be the earliest cognitive manifestation of incident dementia and be a marker for underlying Alzheimer's disease. And so what we are looking for are additional markers. And that's where behavioral changes and neuropsychiatric symptoms come in. These have historically been looked at really as independent risk factors. You look at the data for depression, for example. Depression is included in many prognostication models, and it's considered a reversible, risk factor that if you address it, then you don't, you take out that component of risk towards dementia. But that's an oversimplification. And if you really look at the compilation of longitudinal studies on depression, it's the later life onset depressive symptoms that are really associated with incident dementia, and chronic and recurrent depression much less so. So the idea was to really better assess neuropsychiatric symptoms to capture that group that can serve as a disease marker as opposed to an independent risk factor. And that's where mild behavioral impairment comes in. And mild behavioral impairment was, the construct we actually discussed and started the work on it 10 years ago at AAIC in 2012. And the power of MBI in detecting and prognosticating dementia comes from two cardinal criteria. The first is that there is a later life onset of behavioral or personality change neuropsychiatric symptoms that represent a change from longstanding patterns of behavior. So it's something new that happens in later life. The second cardinal criteria is that these changes are persistent. So one can say in the context of stress, a move or conflict, you might develop some neuropsychiatric symptoms, but then they resolve. But in cross-sectional associations, those get caught, and as case positive in the models, and they just confer a lot of noise. And for example, we did a systematic review and meta-analysis on CSF studies with neuropsychiatric symptoms in MCI and AD. The lead author in that is Dr. Corinne Fisher. And what we found was the signals were all over the place. There were positive studies, there were negative studies. It was inconsistent because the approach to NPS, case ascertainment is imprecise. You think about a geriatric depression scale. The reference range is 1 week of symptoms. And if you think about later life emergent and persistent neuropsychiatric symptoms, you might catch them with the geriatric depression scale, but you might get noise as well, because it's silent on age of onset and it's only 1 week of duration. So the MBI criteria were developed to really find that high risk group. And when you do that, the bulk of our data then show that really is effective at generating more precise estimates of risk in a group that are more likely to progress. And as I mentioned, the longitudinal data have been very supportive of this construct. We recently published in Neurology a paper that looked at groups with MCI that had no NPS, that had neuropsychiatric symptoms that met MBI criteria, and then the in-between group of neuropsychiatric symptoms that did not meet MBI criteria. And what we found was that the MBI group better associated with progression to dementia, but had the lower reversion to normal cognition. So again, that precise group. So then this study presented on p-tau here at the AAIC was the extension of that to include the biomarkers this time. So we caught, in this case, dementia-free individuals. and then stratified them based on whether their neuropsychiatric symptoms included, met MBI criteria, and those that did not, and then those had no NPS. And then cross-sectionally, we measured, we assessed the differences in plasma p-tau levels. And then longitudinally, we looked at, using linear mixed effects models, the changes in those p-tau levels over a 4-year period. And using similar models, we looked at changes in cognitive scores on the Rayvolt auditory learning test, as well as trail making test for executive function, and then rates of incident dementia over 4 years. And what we found was that MBI group, even at baseline, had a 8.1% higher plasma p-tau181 level, and then the changes were greater in the MBI group than the other groups over time. That the MBI group was associated with faster cognitive decline over those 4 years, and an almost 4-fold higher risk of incident dementia by 4 years. So the take-home message is that we can use this as an additional proxy marker, disease marker. And we are used to ascertaining risk based on baseline cognitive status. So normal cognition, subjective cognitive decline, mild cognitive impairment, and then dementia. And so for the pre-dementia stages, we kind of get a sense of risk, with each, especially the subjective cognitive decline and the MCI. But then if you overlay behavioral risk as operationalized by MBI, then you can stratify each of those groups into a higher and lower risk group. So in normal cognition, especially when it's hard to really get good cognitive measures of risk, because by definition, cognition is normal, the MBI group then captures that higher risk strata. In MCI, it's the same. If you stratify mild cognitive impairment by MBI and not, that MBI group is associated with the AD markers and instant decline, and the same in subjective cognitive decline. So it's a way of efficiently and inexpensively, because it's free to determine neuropsychiatric symptom status depending on how you do it. In this study, because we were using legacy data, we used 2 visits with the neuropsychiatric inventory or the NPIQ to determine that persistent neuropsychiatric symptom burden, and we excluded those who had past history of psychiatric conditions. So that way we are capturing emergent, the new onset. But it can be done at a single visit using, for example, the mild behavioral impairment checklist, within which it's explicit that symptoms are of new onset representing change and persist for at least 6 months. And then that allows you to capture a group. And then if you're, for example, in clinical trials, if you require biomarker positivity for entrance into a trial, we're historically using whatever risk markers that we can, usually subjective cognitive complaints or objective cognitive impairment. And then we might do a plasma test to see if they're amyloid positive, or we might need CSF or even a PET scanner. You can do really detailed neuropsych testing. You can do genetics, right? All of that costs time, money, and effort. But if we can get a basic cognitive status and a simple behavioral risk, MBI or not, that can be implemented at various levels at clinical trial to capture a higher risk group, at a public health level, if we need to determine, risk in the community. And that is also easy to operationalize in clinic. Historically, when people came to a cognitive neurology clinic like ours, and they had subjective complaints and were worried about it, or had some depressive symptoms or some frustration intolerance, they would be either told they were fine and considered worried well, or they would be given a psychiatric diagnosis and then rerouted. And the same, if people come to psychiatric care with later life onset psychiatric symptomatology, they could be given a psychiatric diagnosis and treated with antipsychotics or whatever medications. And dementia isn't on the differential diagnosis. But this way, if there is that risk as evidenced by new onset, emergent, and persistent neuropsychiatric symptoms meeting NBI criteria, then dementia needs to be considered, and you would then do whatever workup is appropriate for your setting in your clinic, depending on your resources, whether it's, say, a geriatric clinic and where CT scans tend to be ordered, or whether it's a cognitive neurology clinic and you get an MRI and you might get other FDG PET testing, or if you have a cyclotron, then you can get amyloid or tau PET, or whatever works in the clinical setting. But the point is that these people are at risk, and if we miss them at that first clinical presentation, they'll come back to us, but once they're grossly more impaired. So that's the idea behind NBI. It's really, we developed it as a construct to serve as a disease marker, a proxy marker, and natural history really allows us to differentiate that from an independent risk factor for disease and dementia.